Good morning. Good morning, everyone. Welcome to today's symposium. Uh, today's symposium is under the Department of Clinical Oncology, but it is going to be a multidisciplinary presentation where I have residents from clinical oncology department and pathology department will give us a talk regarding multiple primary malignancies. So I hope those who are online can hear us. If you can, one of you can confirm with us so that we can start. Dr. Nobu. So I think we should start. Okay. So welcome the first presenter. So if you have questions, please put your questions aside, and then we'll have time at the end to discuss. Okay.
Good morning. Welcome to today's symposium, facilitated by the Department of Clinical Oncology, with the topic one patient, two battles, disciplinary approach to neuromalignant cancers of prostate and ovarian. It is presented by me, Dr. Ron and then my colleagues from the Department of Clinical Oncology and from the Department of Oncology. This is the outline. To start with, we have been witnessing increasing chances of patient being diagnosed with multiple malignancies due to advances in survival outcomes in diagnostic approaches. So, multiple malignancies are defined as two or more histologically distinctive malignancies in one individual. So, secondary primary cancers, they show a high incidence rate and they present the primary cause of mortality in patient who has the first diagnosis of cancer. This is a strict definition of multiple malignancies. It is shown by one indicates in 1932. Each tumor must be histologically malignant. Also, each tumor must be anatomically distinct. If we have found the same anatomical science, they should be present by 2 centimeters. again, the second one is the most important, the possibility of one being metastasis or recurrence of other was excluded. So mortality classified multiple malignancy is synchronous and metaconus. Synchronous means they will occur, the diagnosis at the same time or at least 6 months apart, while metaconus they occur at least the second is diagnosed more than 6 months. So this is the instance. The instance values are across the literature, but it ranges from 2.4 up to 19%. So survival of expectancy primary cancer at least exhibit increasing risk of the second, which ranges from 1.27 to 2.6. So several studies have shown that second malignancies such as the prostate show difference of the secondary malignancies. So this is a review from a meta-analysis which investigated the instance of secondary malignancies. So it showed that certain types of cancer exhibiting difference of the secondary malignancy. We have with the highest instance, but it is rare, is the ureter. It shows increased incidence of the secondary malignancy. But for our concern, we have the prostate here, one of the most the second common cancer. So it is shown that it has another increasing risk of the double malignancy. Also, we can have other in the uterus with increased incidence, and also the uterine bladder community specifically. It is an increased incidence of the secondary malignancy. So this is the mechanism behind. One of the mechanisms includes the genomic changes which are caused by the treatment, by the chemo, including anti-solid fibrosis, and also by immunosuppression caused by the domestic primary cancer. Also, we have the related primary levels, like the cancer of the lung, and also the cancer of the stomach. Due to the elevation of hormones, it can lead to development of the secondary malignancy. Having included kidney hyperventilation, also activation of signaling pathways, and the changes in the DNA. So now we come to the focus of our today's presentation. Our case here is a dual presentation of the prostate and bladder cancer. These are the most common urological malignancy in men. So the risk of urologic each one can be the risk of the result of the increasing incidence of each cancer in adult men. However, there is a molecular association between the two. This is the epidemiology. Especially the secondary diagnosis most frequent cancer, and there is a huge leading cause of death in men. So, coming to the brain is 9. Most common malignancies. And also, we have interesting finding here. Following radical of prostectomy, which is a surgical procedure for removing both prostate and the uterine bladder. Incidental prostate cancer is found in at least 23 to 40% of all specimens collected during the procedure. So some studies even suggesting the incidence can be up to 70%. But among these, 1% of them are of the clinical importance. So when you have prostate as your first primary diagnosis in cancer, the cancer is that you develop other malignancies. They can be metaconus or they can be synchronous. This graph shows that when you are having prostate as your first malignancy, focusing to the urinary bladder, most of cases here, as you can see, here are metaconus. That means the developer is 6 months after the first diagnosis. This is according to Tanzania, we have the prostate as the secondary malignancy in terms of both death and the incidence. Also, the better is time to malignancy. We don't have specific data for now detection of both prostate and uterus. This is a shared risk factors. The including smoking and alcohol, the including advanced age, and the radiation therapy of when the first diagnosis is a prostate cancer. So when you irradiate the disease, there is a great chance of the second malignancy. Also, the genetic position, there is the molecular association between the two. You have comorbidities like diabetes is also associated with both of the malignancies. Also, have some environmental exposure to pesticides or patient exposure and the affects the management, including the nutrition. The lack of vitamin D, especially in the setting has been associated with both malignancies. This is the genetic pathway. So there are shared genetic pathways, including changes in the tumor suppressor gene, 53, and then also inactivation of the glioblastoma gene. Also, we have the linear repair defects, which are involving homologous recombination in the basic decision event. So, in diagnosis, we start with the current clinical history with emphasis on excluding the secondary malignancy to be the event established for recurrence of the first. Also, we can do a laboratory test, especially the PSA, and in the image, when you have prostate is your first diagnosis, you can do multi-parametric MRI. Also, you can proceed with the CT or the array of the data. Also, PCT is important to rule out metastasis. Also, in the process of urine bladder, you can do endoscope or cystoscope, followed by histopathology, which is a cornerstone diagnosis of the double malignancy. So, this is the survival outcome. The survival basically ranges the average living 56, but it ranges from 40 to 62, which is affected critically by the tumor type. Metaconus malignancy have poor prognosis because they occur at the same time. So the synchronous malignancy have poor survival outcomes because they occur at the same time. They have conflicting treatment approaches and toxicity. Also, the cancer stage, when it is the stage 4, when it is muscle invasive, better, it is poor prognosis. Also, morbidities, including diabetes and hypertension. Lastly, we have the histology. When you are facing diagnosis, when you is the second, it is common spreading as normal, it shows poor prognosis. That marks the end, and they will proceed with the next presentation.
Thank you, and we're going to continue with our presentation. And of course, the essence of the selection of this case is to highlight the challenges faced when treating double malignancies, especially where we have different histologies. So because of that, we chose this case so that we can be able to highlight the importance of also multidisciplinary teams when it comes to the management of these cases. So our case is of a 74 years old male who is from the Point region. He was referred to the Ocean Cancer Institute on 27th January of this year. He was referred from the hospital, and the main complaint during the time of presentation was a recurrent hematuria, which lasted for over 2 years. So his condition actually started in 2022, where he presented with symptoms of lower urinary tract symptoms, and then he had assessment was done. Two biopsy specimens were taken, and then it was confirmed that he had prostate carcinoma and a lesion scope of 9, and for which he was placed on ADT, which was it was really and also for a period of time. So now about a few years later, like around 3 years later, he presented again with another new presentation where he had hematuria, which was lasting for over a period of 2 years. So during this time, his condition, this hematuria was associated with painful urination. He also associated with posturing and dribbling, and that of increase in frequency, but there was no urgency during that time. So he also was treated for recurrent urinary tract infection, and he had multiple courses of antibiotics prescriptions. So his symptoms continued to progress. Because of that, it led him to seeking further care at the hospital where there was a cystoscopy done, and then subsequently a first TURBT was done. And then after the first TURBT, he had mycomycin, which was instilled, but then yes, he still presented with the hematuria, which led to the physician going for a second TURBT. And then through the first time, the specimen taken was classified him as, diagnosis of bladder cancer, but at then it was grade 1. But then later on, the second TURBT was done because of the persistent urinary hematuria. He was then staged to muscle invasive, because we're going to see from the slide where there are features that made the diagnosis to be led to that point. So he had 2 TURBT. Now, after this, he still continued to have this hematuria. Because of such, he was then referred to Ocean Road. So in his past medical history, he is a known hypertensive who has been on anti-hypertensive medication, the losartan and that of amlodipine. He's also a known diabetic, which was also on metformin. But he also had a person in his history of polyditiasis in 2015, and then also he denies there was no exposure or diagnosis to schistosomiasis, which is one of the risk factors for bladder cancers. So in his family social history, he is divorced, a retired health laboratory assistant. He has no history of working in the industry, but he has a positive history of cancer in his family, where his sister died of cervical cancer. And he also has a positive history of alcohol use, but there was no history of tobacco smoking. So on physical exam, he was seen in a fair general condition. He was alert, he was not jaundiced, he was not dyspneic, he was afebrile to touch, there was no edema, there was no palpable lymphadenopathy. His vital signs during the time of assessment were these, and then his performance status were these, which were actually okay. And then the musculoskeletal system exam, there was no pertinent findings. So our plan now for him, after assessing, considering the history from the time of my meeting up to the time he has met us, this was our plan. We did we order abdomen pelvis MRI and that of chest CT scan. We also ordered echocardiography because of the history of hypertension, and then also ECG, and as well as the HbA1c because we wanted to understand the glycemic control period. So we decided to order this, and then we also ordered some routine labs, which was the full blood pressure, the renal function test, and the prostate specific antigen level to assess to see. So, as results came up, these are just the number of findings that we had where there was evident renal impairment seen with these with our lab results. But other parameters were okay for his blood work. Now, back in 2022, these are images from the radiology department where here for the first image here, which shows this is a view of the pelvic region. As you can see here, this is the prostate gland here, but as you see, the prostate gland is enlarged here as compared to the normal size. And then at this point, you see this is a focal lesion as here of incompetence. But around here, there is clear demarcation which shows that there is no extracapsular extension. of the prostate. And then here, also this is a coronal view of the same pelvic region showing the bladder, wherein there was seen bladder wall thickness, which was about 2 centimeters. So another MRI, which now was in 2025, noted multiple bladder lesions here. What pertinent in this area was this obstruction here at the vesicular junction, and we're going to see the findings that's going to be seen as a result of this, because here there's a lesion that caused obstruction, and as a result there were development of hydronephrosis in the left kidney. So we're going to see it as we go forward. Now, at this point, this also the chest is done. It shows multiple heterogeneous enhancing lesions here. And particularly here is this here at the upper lobe of the left lung here, where we see. So this also have been we've been considered as whether this would have been either a primary, a third primary, or would be metastasis. So we're going to see the next step after seeing all of these findings. We're going to see the next step of our intention for this patient. The next year is also this lesion that is formed in the lumbar vertebra here. Also, we also have the thought that there was also spine metastasis. So now at ORCI this year, this was the MRI that was taken, and present at this multiple bladder wall papillary non-conjunctival mass, and of course there was perivesical fat extension. The bladder mass was extended to the perivesical fat, and because of it leads to a specific staging for this patient. And then also there was a lesion that was noted as described in the initial image also, which toward the left vesical ureterial junction, and then it caused obstructions of the incisor area, urea, and then it resulted into ureterial dilatation. And as an end result, he had left hydronephrosis with also right renal cortical cyst was found. So at this point, I'm going to give a break to the pathologist to discuss this slides, and then I'm going to come back with the management of this patient.
Good morning. Let's continue with our first presentation. These were the histological slides which were taken during the diagnosis of the patient. And in front here, these were the sections from the prostate, which was the first cancer to be diagnosed. So the patient underwent QRPT, and prostate fragments were resected, and these were the histological sections. I put this picture here on our left side. This is a prostate tissue with nearly normal prostate glands, which we can see they are somehow larger, and were also found on the same section having cancer. But we put this for just comparison. But you can see in our right side that is the same prostate tissue, but here we can see that the normal glandular architecture of the prostate are lost, and we have small microglands which are haphazardly arranged and proliferated. Now, this depicts the same picture, having glands which are microglands irregularly arranged and fused, and this arrangement tells us about the aggressiveness of the tumor, meaning that the more the glands are deviating from the normal looking of the non-prostate glands, the more the cancer aggressive is. So we can see this one, but in comparison with this, we
which was found among the sections, we can see only individual scattered cancer cells, which tells us that the cancer is more aggressive. And this provides us the cornerstone of histological grading of the prostate cancer by using the Gleason score, which our colleague mentioned that it was score 9. And that classifies the patient in the group of high-risk patients, meaning that this cancer is high risk, it's very aggressive, so that it is predicted probably to recur and to have instant metastasis. Now, this is among the features which try to show us even more aggressive features, including this one, which is perineural inversion of the tumor. You can see these nodes surrounding a nerve bundle. So all of this signify that the patient is having the high-grade tumor, which requires urgent attention and probably multimodal treatment. Now, this were a section from the urinary bladder tissue. We can see also there is a cancer or a tumor, and this cancer is quite different from the one we saw previously. The one had a glandular differentiation, the glandular tumor. This one is not the glandular tumor. Instead, they are just tumor cells, which you can see they are haphazardly arranged. As you can see, that this one should be the non-urinary epithelium, which we know that there is an orderly arrangement of the epithelial cells, followed by the other layers, the propria, lamina propria, and the outside should be having the muscular layers, and the outside, most outside there are perivesical fat. But here we can see that the tumor is growing and it is invading the muscles. So this deep pink, or yes, this deep pink color depicts the muscle, and this growth of more purplish color, the tumor invading the muscles. The same, the tumor was showing squamous differentiation, meaning that they were deviating from the normal bladder epithelium into the lining which resembles the skin tissue, which also signifies the aggressiveness of a tumor. So this shows diffuse tumor. There were areas of necrosis, and this shows the high-grade nuclear atypia. Here you can see that the cells they are significantly varying in their size, and there can be a lot of things here telling us that this tumor is highly aggressive and highly proliferative. There are a lot of atypical mitosis here. The cells look more purplish, the sign that they are highly proliferative. So in this two tissue, we can see that the patient is having two different cancers, and not one maybe extended to the other. Maybe one from the prostate, because they just be diagnosed to extend to nearby structure of the bladder, but they are two different cancers. Thank you.
All right, so after seeing all of the clinical findings from the imaging, from the history, and that of the pathology slide we have just reviewed, for the case of the prostate, specifically that the prostate was no extension, so it gave us a T stage of 2, and then there's no lymphadenopathy, single lymphadenopathy, so we have it at N0. And then we are considering, because there is metastasis. At this point, we have to not sure whether the metastasis is from the bladder or from the prostate. So we take it at M1C because there's no and that that of the land so kept at sea. So we now query either there will be bone metastasis in this stage or there will be lung metastasis after our next plan that we'll be looking at after the year. So also because of the usual scope, because to classify prostate cancer patient either at high rates, low rates, intermediate rates, there are some classification you have to look at the PSA level, where it has to be at least greater than or equal to 20, and also you can have the visual score at least greater than or equal to 8, and then also for the T stage, which is should be at least T3 or more. So within that, at least one of them, when they are evident, we consider that patient to be high risk. So at this point, we have a visual score of 9, so getting our patient to be a high risk patient. Now for the bladder, from the last MRI that was done at Ocean Road, we saw that there was perivesical fat extension of the bladder tumor, which gave us the T3, and then there is no lymphadenopathy, so we have it at N1, and then also the suspicious metastasis, for which we are not classified to be as whether metastasis from the prostate or the bladder, we have it as M1. So now it's being considered as mostly invasive bladder cancer with paraaortic. There was suspicious paraaortic lymphadenopathy, but after reviewing, we did not find it. So sorry for this, we did not omit this one. And then we are thinking this, we are querying lung or units. And we also thinking, can that lesion seen in the upper lobe of the lung be a third primary malignancy? So from this point, we plan that first there should be an urgent bilateral, let's say it's not bilateral, left nephrostomy tube insertion or stenting to reverse the obstruction that is seen because resulting to reform nephrosis. Also to reassess the patient after the insertion of a PCM or stenting to see as well there is improvement in renal impairment. And also we intend to do the prostate-specific membrane antigen PET CT because it is going to put us more towards whether the metastasis we are seeing is moved from prostate, so we can limit our invasive procedure we need to do to have the interventional radiologist to be able to go for biopsy and then look at the histology of that. So we will do more for the PSMA PET to be able to see as whether the metastasis is for the prostate. But also, if we cannot do that, we intend to do bone scan. We can also be able to stay specifically as to whether there is actual metastasis there. And then we would have to consult the interventional radiologist for biopsy of the lung mets and other could be a bone, because we want to see as to whether the lesion that is seen in the lung is actually metastasis or it's a primary lesion. So as a result of this, we're going to now go to our next course of action, where we're going to have possible intervention for our patient. So we have 3 possibilities. We have organized 3 possibilities with the idea that there's possible metastasis in this patient based on the imaging findings we have seen. So we start here as follow through from this first place. So we said if the prostate is localized and then but the bladder is the one that has metastasis, we will go for systemic therapy palliatively. We will use chemotherapy and also use immunotherapy for this patient. And more likely we can have pembrolizumab to be used. And then also depending on symptoms, if we want to have symptom relief, if the patient is having symptoms, we can opt for palliative radiotherapy for symptom relief. And then for the prostate, we can place the patient on ADT. And if the second point, if now the bladder is the one it is localized, and then the prostate is the one that is having metastasis, we can add for the duplex therapy for the prostate. That is when we have the ADT, and we also have docetaxel for this patient. But considering that if the metastasis seen in the lung is actually from the prostate, it makes us to have as a high volume disease. So because of that, we can opt to go for triplet therapy with abiraterone to ATT plus docetaxel. And also, if we can also go for the SDRT or ablation, and we can also, if there is bone metastasis happening, we go for a bisphosphonate, isovaleric acid, and we give it based on the renal impairment, creatinine clearance is okay, depending on the creatinine clearance, we will give isovaleric acid. So now, at the last point here, if the both tumors, they want to have a metastasis in there, so we go for systemic therapy for the bladder. We can give fludarabine and cisplatin, or we can also go for immunotherapy. So for the prostate, we go for triplet therapy for the prostate, or we can make it triplet by the addition of abiraterone plus prednisolone there. And then also, if there is any need for us to do the serotonin body therapy, we can also go for that. And then, of course, intervene with the bisphosphonate. So far, this is going to be the specific management for our patients that have been presented. But the next presenters are going to come to look at for the general management for patients with renal malignancies.
Good morning. So to wrap this up, we're going to discuss on what is the approach to management of patients with double malignancy if they have bladder and prostate cancer. So as highlighted in this algorithm, we're seeing the treatment options for both malignancies. So we have local treatment and we have systemic treatment. For prostate cancer, surgical options include prostatectomy. We also have the option of radiotherapy. In case of systemic therapy, we use androgen deprivation therapy, chemotherapy, or immunotherapy. In the case where our patients have low survival time, we have the option of observation as well. For bladder cancer, our surgical options are TURBT, which is resection of the bladder tumor, or radical cystectomy. Local treatment can also be through radiotherapy, and systemic treatment options are chemotherapy and immunotherapy. So we'll go into details about some of the things that we consider in management of prostate cancer. In terms of staging, we consider the T stage, the nodal, if there's nodal involvement, and if there's metastasis to any distant organ. The PSA is also important, and the grade group, as we'll see in the pathology report. So this is a pictorial demonstration of what informs the TNM staging for the prostate. So T1 is a clinically an apparent tumor. T2 is appreciable prostate tumor, but then it's not outside the extraprostatic region. In T3, we have the lesion going outside the prostate. It could be invading the seminal vesicles. And lastly, T4 is if we have infiltration into organs like the bladder or the rectum. So the other consideration for prostate staging is the risk stratification. In the risk stratification, we're considering the T stage, the grade group, and the PSA. So as we move from low, intermediate, high, or very high risk group, these parameters are increasing progressively. And this is important because we can see for high and very high risk, there's a possibility of metastasis to the bone. In that case, the recommendation of doing bone imaging is recommended whether the patients are symptomatic or not. In terms of treatment options, this is an adaptation from NCCN that shows us the things to consider in treatment for prostate cancer. And the main thing we are considering is the expectant patient survival. So does the patient have a survival of 5 years or more and they are symptomatic, or it's less than 5 years? In that case, we're considering options like radical radiotherapy, hormonotherapy. There's the option of prostatectomy or observation. So that's highlighted in the different arms. In the case where the patient has metastasis, we're considering if the metastasis was diagnosed at the same time as the primary, hence synchronous, or metachronous if it came thereafter. Another consideration is on the volume of the disease. If the disease, the metastasis is confined to the bone, how many lesions are involved, and if there are other visceral organs involved as well. So it will be low volume or high volume. We have the options of androgen deprivation therapy in combination with other agents like abiraterone or inclusion of chemotherapy as well. And in the case of low volume, we also consider radiotherapy for prostate, for the prostate itself. For the bladder cancer, the staging is dependent on the infiltration into the bladder wall. So we can see T1, it's just limited to the lamina propria, but from T2, there's invasion into the muscularis propria. By T4, we are going into the adjacent organs like the prostate or the seminal vesicles. The nodal staging is also considered, and in the case where we have disease nodes involved being limited to the pelvis, it will fall under the M staging. But if we have nodes outside the pelvis, like in our case, the para-aortic nodes, then we'll be talking about metastatic disease. So for patients who are suspected to have bladder cancer, the first approach is to do a cystoscopy. Once that's done and it suggests a tumor, then TURBT can be done, which is followed by administration of intravesicular chemotherapy. This gives us the staging of whether the cancer is muscle invasive or not, and this is important for our treatment consideration. So in the case where we have pathological confirmation of muscle invasiveness, our options for treatment include neoadjuvant chemotherapy followed by surgery, or we can do surgery alone, or bladder preservation treatment as we'll see later on, which is basically doing maximal TURBT followed by chemo and radiotherapy. In the case where we have metastasis of the bladder, our options are limited to systemic therapy. There's also consideration of palliative radiotherapy, where we're trying to control symptoms like hematuria or pain. So this just highlights the options for systemic therapy, which could be immunotherapy or different combinations of chemotherapy. An important consideration being the renal sufficiency of the patient. So when it comes to radiotherapy treatment, if we're managing a patient with both bladder and prostate, we want to optimize the dose that goes to the tumor, but have minimal toxicity to the normal tissue. So in the case where we need to treat both of them, there's a concern where the volume may be large, so there'll be increased risk to organs like the bladder and rectum. In that case, we will need to consider doing intensity modulated radiotherapy, where we're trying to conform and have the dose being maximally delivered to the tumor while sparing the normal tissue. Another consideration is the dose that's being prescribed. So different organs in the body respond differently to radiotherapy. We have those that tolerate higher doses more than the other, and an example of this is the prostate and the bladder. Therefore, we need to find a balance on how we can safely administer a dose that will spare toxicity to even the sensitive tissue. Another consideration, when planning radiotherapy, the goal for us is to have reproducibility in the subsequent sessions. So we want to control physiological factors like bladder filling, and in that case, if we're radiating the prostate without the bladder, we will ensure that the bladder is filled so that it pushes the bowel up and reduce toxicity. In the case where we're treating both of them, there may be a challenge, so there may be increased risk of toxicity to the bladder. So the other difference or the other consideration is the role of chemotherapy. When we're treating the bladder, as you see, it's given a concurrent chemotherapy. But for the prostate, we do mostly hormonal therapy. So if our patient is to receive both of these, then there's a concern of increased toxicity with the combined therapy. Lastly, if we have a case whereby the two malignancies are metaconus and the patient has received radiotherapy before, our concerns are the altered anatomy, the dose constraints, basically what toxicities have the normal tissues been exposed to already. So in terms of surgical management, as you've seen, prostate cancer, we've seen the option for surgery in the case of local prostate cancer is prostatectomy, while for the bladder, our two options are resection of the bladder tumor. And in this case, TURBT can be done alone, or it can be done in combination with chemotherapy and radiotherapy in the case where we want to preserve the bladder function. This TURBT can also be repeated in the case, as we've seen before, in case the pathology did not include the muscle invasiveness of the disease. So cystoscopectomy is a more radical treatment where bladder preservation is not reserved. This would entail removal of the bladder and the prostate amongst other organs. and systemic therapy could be given before this in case the patient is able to tolerate. So as we've mentioned already, bladder preservation would be an option in case where radical system prostatectomy is not able to be done. The considerations for patients who qualifies for this kind of treatment is if there's T2 or T3, if there's good capacity of the bladder, and if the renals are working well, because as you've seen, this would entail combination of chemotherapy, which could be toxic to the kidneys as well. So any patients outside of this scope, if they have bulky extravesicular extension, either renal issues or poor bladder function, would be excluded from consideration of TMT. So there was a retrospective propensity score matched analysis that was done that was comparing TMT versus radical cystectomy, and the findings were that there was improved 5-year overall survival in the patients undergoing TMT of 73% versus 66. So basically, this is a justification for patients who meet the criteria for TMT to undergo this treatment option. And it was seen that of the patients who underwent TMT, only 13% of them required salvage cystectomy thereafter. So the key challenges in managing a patient with double malignancy, we're seeing that there's limited evidence-based approach of management. As we've seen, the treatments have already been shared, have been specifically for prostate and for bladder. So we don't have a combined evidence-based approach. Then another consideration is the sequencing decision. Which treatment do we start with first, considering the effect of the toxicity to the normal tissue? There's also conflicting chemotherapy regimens, and again, we go back to the issue of toxicity and patient factors. So most patients with bladder and prostate tend to have advanced age, and they will have other comorbidities as in our patient. So the ability to tolerate aggressive combined therapy may be an issue. So in conclusion, we need to manage these patients together. We've seen the involvement of the different specialties all the way from diagnosis, in terms of confirming the pathology, getting the radiological evidence to support our diagnosis, and also in terms of treatment. We see the role of medical oncologists in terms of chemotherapy, immunotherapy, hormonotherapy options, radiotherapy, in terms of options for radiotherapy, either curative or palliative. We've seen the role of the internist in controlling the comorbidities like diabetes and hypertension. Therefore, we need coordinated treatment and continuous reassessment as a team. There's also the need to establish clear treatment priority and to individualize the treatment strategy depending on the status of the patient and their preference as well. So thank you for that. I will invite our moderator to help us with the next question.
Very well presented by all of the speakers. So I think we have about 15 to 20 minutes for discussion. So I'd like to invite all the presenters to the stage. If there are any comments, questions, clarifications, time. Maybe I'll start with one question regarding the lumbar lesion. So, was it symptomatic or not? What is the plan for that?
Yes, so for the lab finding, especially the renal function test result. The number. Yeah, so he reported back pain. So we intend to do, that's why we intend to do either the bone scan or the PSMA PET to be able to assess, to see. And also we intend to do biopsy to be able to know the histology as to whether that's actually metastasis, and if which one of the two primary malignancy it is from. So that's that. And then also when it is confirmed that is metastasis, we intend to do wound protection where we have to do 4 days. This phosphonate, like this nucleic acid, observing the renal function, the creatinine clearance, guiding us to do this one.
Any other question?
Thank you very much. Presentations all very well done. It's a difficult case, difficult presentation, and to juggle all the elements of this case, which you managed very well. I think also our colleague from pathology, because when we were preparing the case, we had this dilemma. We really want to prove that these are two separate histologies, and we did a good job in doing that. So, the current dilemma is how do you manage these two primaries simultaneously? But we know that started in the process, right? So what is the current status in terms of the PSA and the development of the process? Can you give us some clarity on how to move forward?
So for the process, there was fluctuation in the levels of the PSA, but none of them was up to 4 nanogram per liter. So the state of the process, we say that because when the next meeting was done, it was the process was okay in size. There was just a bit of classification noted. So particularly because of the China TRP that was done in post-procedure, maybe that's why I was showing that findings. But so far for the process, yeah, there was not much problem. The main issue has been from the metastasis in that also the bladder cancer.
So would the team be confident in saying that we will focus on treating the bladder cancer now the prostate cancer is very much
We will not ignore the management for the prostate because there's a possibility of, or even though the PSA has been controlled, we cannot ignore, but we're going to focus more for the bladder because it is more likely the one that is of concern, the more aggressive at this point. So we would like to focus more on it to address it. And then since the prostate has been seen to be normal in size, we can just continue on the ATT.
And then the next question is regarding the images that we showed on the non-metastasis. So based on the discussion with the radiologist, what does that lead to? Does it look like a primary lesions, systemic lesions? What kind of additional?
So we were thinking more in this metastasis instead. Yeah, we're thinking more in this metastasis. So to be sure, we intend to do the biopsy and then to look at the histology whether it is similar to any of the two primaries. We will consider if it is maybe the characteristics is we will be able to have as a third primary.
Any other question?
Thank you very much for a very nice presentation. It was very well done. I just have a few questions since you have done very detailed search once you're present. So is there a need of developing, let's say, a tool for risk stratification so that we can put maybe our patient to a follow-up, maybe 6 months after they're treated for the first primary, maybe we can put them on a 6-month follow-up with some risk stratification or maybe some genetic testing so that we can assess the predisposition of these patients for developing a second primary. That is my question. Is there a need for that? Or maybe we should just wait for them to develop symptoms that will diagnose them?
The patient is already classified as high risk, considering the Gleason score. Because we have 3 parameters that we use: the T stage, the PSA level and the gleason score. So the gleason score are reporting at high risk. But if you will want to assess for maybe there is some genetic predisposition where there is a syndrome consisting of the breast, ovarian, and prostate cancer, where it involves a BRCA mutation. If there's a possibility, we also do that. But for at this point, that could be a subsequent decision. But the primary objective at this point is to be able to ensure that we address the pending and the present issue, and from there subsequently develops and follow. And even genetic counseling can be done at the aim of his relatives.
We had actually two missed opportunities to discuss it. The first one was a diagnosis of systolic diabetes in 2015, which can put the patient at the risk of developing urinary bladder cancer. So it was only brought up again in 2020. We had the imaging showing thickening of the urinary bladder, although there was no comment in the radiology report, but that was necessary to make a follow-up. In the screening for bladder stage, a simple projective, you cannot even say use the sample for screening. So it was not done until it developed 3 years later. So this is not the double malignancy, the dual presence of breast and the prostate is a common phenomenon. So in your patient diagnosis, a necessary follow-up. If you are follow-up, you should be able to think that the patient may be also having the risk of developing the next malignancy. In case of urinary bladder, we have simple tools for screening for prostate, a simple PSA, and DRE is important. So, as you have seen, it is some studies in the sample collected, it is up to 70% of the sample in children. So, it is important to continue screening for both malignancies, and over time, there is no genetic testing. I presented on the sharing pathways, the genetic alterations. There is no genetic screening for possibility of both malignancies in a cell fashion.
Okay, I didn't have exact questions, but I'm take the room for asking you to make a comment. So this was a very good presentation. So congratulations to all the presenters. It was very well elaborated, and it's a complex case that is so that we are able to follow. So maybe an additional getting the genetic predisposition. So this patient has a second primary weakness, and there is also a pulmonary lesion, which is also very primary malignant. And also in the family history, we mentioned the patient has a sibling who also passed away because of the so probably this patient has a familial or something of inherited genetic predisposition to malignancies. So there is the Elvis syndrome, which predisposes patients to multiple malignancies in their lifetime. And so maybe this is so exciting point that we need to strengthen our genetic testing and facilities for genetic testing and to put other genetic syndromes which predispose patients to malignancies that are not just studied in our population. Yeah, so let's get some. Thank you.
Thank you. I would like to comment also the presenters for sharing well about the topic. Maybe I will ask one question. Number one, So apart from the bladder, the prostate, and the lungs, okay, is the effect of the tumors or the treatment and other possibilities like the paraneoplastic syndromes. So if you assess, for example, the nervous system to see if at all the individual has any neuropathy, which may be because of any either the tumor itself or the treatment or paraneoplastic syndrome. Thank you.
Yeah, so for assessment, we did not find any nervous system findings in this patient.
So, yeah, I think that bring us to the end of this session. I'd like to thank all the presenters. Please, a round of applause. And then I would also like to thank all of you for participating in this session. I'd like to remind you that we have attendance registered. If you not registered, so please do that because this session has been CPD booked as well. So please register. So yeah, I'd like to thank you again. See you next time.
Thank you. Yes. No, but thank you. Thank you. Thank you. Yes. Yeah, sure. Yes, I will.